Hello, Pima class. I hope your week has been well and you enjoyed some of the nice weather. So this week we're going to talk about reproductive systems. So I'm going to give a little disclaimer. If you're watching these videos or listening to out loud and there are small children that you don't want them to know or see anatomical terms or anatomy itself, I'm going to ask that you take a moment, bring your screen away from them, and sit down. Okay, now that we've got that cleared out of the air, you're going to hear penis, 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 vagina, vagina, vagina a lot, and we're going to talk about some sexually transmitted infections. So there's going to be some gross pictures that are not super child friendly. Hopefully that was enough time. Dr. Wood, she's going to go a million miles a minute when she doesn't intend to, but that is where it's at. So let's talk about the male reproductive system first. So first and foremost, males and females, embryologically, we all start the same. We start as two cells, a sperm and an egg, that form together to form a zygote. And from that zygote, lots of multiplication, lots of division occurs. And around week 14, our genitals in utero still look the same, still look exactly the same. Around week 15, for the most part, around week 15 is when either estrogen or testosterone are starting to be produced from either the ovaries or the testicles biologically. And that's what causes more of either the enlargement of the penis or the formation of the clitoris into a smaller portion. So in the beginning, we all look the same, okay? As far as reproductive systems, so in humans, this does not become active until puberty. We are not chickens. We are not anything else. Sorry, I'm walking around my office. I can close my doors so my poor office manager doesn't have to be screaming vagina a million one times as she laughs. All right. So the purpose of the reproductive system is to procreate or reproduce. Of course, it can be fun to recreate, but for what our purposes of this topic, we're going to talk about reproduction in the forms of procreation. So each male and female, when purposes of forming another human being, the male is going to donate a sperm, which is known as a gamete or a sex cell, and a female is going to donate an egg or a gamete, and that is also a sex cell, and they come together just like I said. So we're going to be talking a little bit birds of the bees, but I'm not going to get into too much depth because, yeah, we don't need to. So as said, sexual intercourse brings the ova with the sperm together, or in modern times, we can bring the sperm and the ova together via in vitro fertilization or artificial insemination. So same-sex couples are entitled or can have babies. Okay, so I'm saying this from a reproductive standpoint. I don't want anyone to think that I am talking about that. Whoever wants to have a baby can have a baby, is my opinion. Okay, so that's just my opinion. So when that sperm and the egg fuse, regardless of how it's happened, it's called a zygote. And that zygote is the first cell of life. Okay, and then after a few weeks, that zygote, well, after a few minutes, that zygote actually starts multiplying, dividing. After a few days, it becomes, we'll learn about a different part, and then a few weeks, it becomes a embryo. Weeks later, becomes a fetus, and then birth happens, and the baby's born. As far as male and females, as I said, we all share, we're the same precursor in utero. It just depends on what's getting secreted. So when it comes to gametes, or the sex cells, there's a special way that these are made. And the gametes are made for males in the testes, biological males in the testes, and for biological females in the ovaries. And the process that we make gametes is known as meiosis or meiosis. Then we have sex hormones. So remember, regardless of sex, we all have the same hormones. It depends about the levels that are available. So in biological males, we're transitioning female to males, there's a higher testosterone level. And the higher testosterone level is what's going to cause a lot of those secondary male characteristics. Estrogen and progesterone in females is going to be secreted at a higher level, and that's going to give female characteristics. And I keep putting things in air quotes because I have a very firm belief that I want to share with you guys, but remember, it's my belief. Everyone's entitled to their opinion. I'm not pushing mine on yours. I'm just sharing a little bit of a different way to look at things. And as I said, no I'm not trying to get into politics here. Okay, and then we have accessory reproductive organs that are external genitalia, the glands and ducts that go along to get things where they have to go. So what we have in common as far as biological males, biological females, or regardless of the two, is that we all have our hypothalamic pituitary gonadal axis. And from the hypothalamus, something called gonadotropin releasing hormone is released. This is released in from the hypothalamus, and it goes to the anterior pituitary. And when this is released, it stimulates FSH, follicle stimulating hormone, and luteinizing hormone. Now, luteinizing hormone and FSH then will exert their effects downstream, which we'll get into a little bit. Okay, these all work as a negative feedback loop. And you might hear of someone going through precocious puberty, which means puberty happening too early, and we'll get to that in a little bit. We also have a hormone called inhibin, and it's released from both ovaries and testes. And what it does is that it exerts negative feedback on FSH and tells the FSH to stop. So it's a negative feedback, but also inhibin can also go back and tell it to stop. Okay. So puberty. We're all here, so we all went through it some way, shape, or form. Not a fun for anyone. But it starts at the HPG axis. So typically, puberty happens normally in females. It can start from anywhere from about 9 to 16. In males, typically around ages 8 to 16. What I'm seeing in practice, in clinical practice, is that puberty unfortunately is starting a lot earlier. And that might have a lot to do with our environment and what we're using, plastics, endocrine disruptors. I'm not going to go into all of that, but that's my soapbox there for the day. If I haven't had 50 of them, now there's another one to add to the soapbox. So before puberty, there's always low levels of these steroidal sex hormones. But there's enough around that it tells the GnRH to shh and not to produce. When puberty approaches, the hypothalamus becomes less sensitive to the sex hormone inhibition, and then it gets a pulse like it goes psh, 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 of GnRH, and this is what stimulates puberty to start. And as we know, it doesn't happen overnight, it happens over the course of a few years. So what does this do? So in response to the GnRH, FSH and LH are released, and then we get into sex hormone release that are similar in releasing, whether it's female every month or males consistently, until an adult pattern of the hormone interaction is achieved, and that's when we have stopped puberty. Typically, that's around 16 to 17 years old. When we're looking at puberty, we stage children on the stages of puberty. So this one is for males. So we go by the size of the scrotum, the amount of pubic hair, and the length and width of the penis. As I said, testes, so remember, biological XY humans have these. Remember that gender and sex is different. I just want to make sure that I want to make that for myself understood. You guys can think what you want. For testes, they lie in the scrotum. And the scrotum is a sac of skin that hangs outside the body, and we'll go into why in a moment. And there's different avenues of how this, and what they do, testes make sperm, and the sperm is delivered through the body through a duct system. And we'll go into that route in a little bit, but in general, it goes from testes to epididymis, to ductus deferens, ejaculatory duct, and urethra. And then there's glands along the way that help add to seminal or semen, which is the fluid that sperm travel into, to make it a nutrient-rich environment for the sperm to thrive. So if we took a cross-section of our male reproductive system here, we have the testes down here. We have the epididymis right here. Vas deferens coming, and it loops around the bladder, goes and into the prostate. The prostate then has these two little bunny ears that hang off the side of it, and those are the seminal vesicles. These bunny ears meet up with the vas deferens in the in the prostate with the seminal vesicles and the vas deferens into what's called the ejaculatory duct, and they come together to form the urethra, the prostatic urethra. We also have another sorry guys, maybe I should be drinking my water. So we also have another gland here called the bulbourethral glands, and we'll get into what that does in a moment. There's these little pea-sized things here, and they help contribute to the semen, then through the urethra until it's ejaculated and out. And I just spilled my water all over myself. Can't do anything today. All right. Well, now I gave myself a bath. Awesome. So scrotum and testes, as I said, it's a sac of skin, superficial fascia. It hangs outside the abdominal pelvic cavity for a reason. Why? There's two testes, one in each part of the skin sac. And the testes need to be 3 degrees Celsius lower than the core body temperature because lower body temperature is needed for sperm production. So that's why they hang out on the outside. Okay, there's a midline septum that divides the scrotum into 2 compartments, one for each testes, and they have their own blood supply, their own nerve supply, their own vein supply, everything. So when the scrotum is affected by temperature changes, and that's a protective mechanism. So when it's cold, the testes will pull closer to the body and to get that warmth. And it does it by 2 ways. We have the dartos muscle, which is a smooth muscle in the superficial fascia of the scrotum that wrinkles the skin. And then we have something called the cremaster muscle, which is a skeletal muscle that elevates the testes. So biological males with cremaster muscle still intact can tell themselves to bring their scrotum in. There's also a reflex called the cremaster reflex that we test on males to make sure this is intact. No, I'm not going to make anyone do that. Okay. As far as where the testes and scrotum and the spermatic cord. So remember we talked about here that the testes hang out here in the scrotum and they are attached to the epididymis. Epididymis then leads to the vas deferens. And the vas deferens is the connecting tube for the sperm to get to the fluid. Okay, to the rest of the fluid conglomerate. So in the spermatic cord, we have a bunch of something called a papiniform venous plexus, which is a plexus of veins, a testicular artery, a nerve, and some fat. And if you ever heard of it, hernia, what happens here is there's this little circle here called the inguinal ring. And what can sometimes happen is that either the intestine, small intestine, can get stuck in this ring somehow and get pushed in, or this part up here can get pushed out. And that can be quite painful for someone. Testes have 2 coverings. The first one is tunica vaginalis, and that's the outer layer. And then we have the inner layer called the tunica albuginea. It's a little bit more white and more fibrous. And then each testes is divided into about 250 lobules, and each one of these contains about 1 to 4 seminiferous tubules. The seminiferous tubules looks like a bunch of squigglies. And inside these squigglies is where sperm is made. Okay. And then sperm goes from the seminiferous tubules to the straight tubule, and the Redes testes, the efferent or efferent ductals, and epididymis. And the epididymis is important. Okay, so a male can survive, a biological male can survive without their epididymis. It actually is a common sign of inflammation and infection, but the epididymis is there to store the sperm and allow it an area to mature until it's ready to ejaculate. And yes, I will be using ejaculation and erection in this lecture. So we already talked about that part. So right in here, the seminiferous tubules, so those little pasta-looking spaghetti squiggles right there. Fun fact, when I used to do autopsies, a way to make sure the testes were actually a healthy testes, you would cut a testicle in half. I know you're like, wow, Dr. Wood, really graphic. Cut a testicle in half, take the edge of my blade and thread it a little bit, or we'll like very finely scrape it and see if those tubules actually get uncorked, unsquiggled. So important to know, and this might come up in clinical practice, about testicular cancer. Testicular cancer, if anyone remembers Tom Green from the late 90s, you can get that song stuck in your head if you want. If you're too young for that, sorry, I just showed my age. But it's rare to have testicular cancer, but there is an onset of age that we like to pay attention to. So males 15 to 35 tend to get testicular cancer. And this testicular cancer, and as I said, no, this is not COVID. This is really bad allergies that just won't calm down lately. I've swabbed myself multiple times. Okay, so 15 to 35, we normally get something called a seminoma, and it's the most common type of cancer to be found in a young male. At age 65, for some reason, there is a gap between this two. And at age 65, a recurrence, or not recurrence, but a age group gets more at risk for testicular cancer, and that's most likely a lymphoma. There are some risk factors for testicular cancer. Sometimes there's something called cryptocorticism, which is the most common risk factor, and that's when the testes don't descend. And we'll learn about that in embryology, but when biological male children are in utero, their testes are already actually still inside their body. And then at some point, at some point they descend into the scrotum. And if they don't descend for some reason, there's this extra caution for testicular cancer. The other part, #vaccines work, is for MMR, measles, mumps, rubella. The mumps component is mainly an infection of the parotid glands, where you get the huge swelling of the cheeks, fever, rash, but sometimes rash. But what the big issue here is that it can lead to orchitis, which is a fancy term for inflammation of the testes, and that's not good. That can actually cause infertility. Most of these are painless solid mass, so we typically tell males to, almost like a breast exam, a self-testicular exam. And then 90% of these are cured by removal of the testes and often get radiation or chemotherapy afterwards. So when we're talking about the duct system, about the males, we're looking at the accessory ducts. We talked about the epididymis, and now we're going to look at the other aspects. So we have the epididymis we already talked about. There's extra information on the side. I really don't want you to know about it. I just want you to know this is where sperm go to mature, okay? What I do want you to know about is that it does have pseudostratified epithelial tissue that contain stereocilia, and this helps increase the absorption area, or the absorption capability of testicular fluid and nutrients to pass stored to the sperm. So in the GI system, we had microvilli, and what were their purposes? Their purposes was to increase surface area for absorption. So sperm need a lot of nutrients, and we need a lot of absorption for that to happen. So non-motile sperm from the testes enter into the epididymis, and they pass really slowly. It takes about 20 days for them to be able to gain the ability to swim, and then they get stored there for several months, okay? And then during ejaculation, the epididymis will actually contract and expel sperm into the exit route, which is the ductus deferens. Ductus deferens, you'll hear me refer to as the vas deferens. I rarely ever call it the ductus deferens. As we said, it's basically a long tube that meets up with the seminal vesicle to form, meets up with the duct of the seminal vesicle to form the ejaculatory duct, and it's meant as a passageway for a sperm and semen to make its way to the urethra. And then vasectomy, cutting or ligating the vas deferens, is nearly 100% effective form of birth control. Caveat, okay? Make sure, if you know anyone who is going to get a vasectomy, that they get a pathology report confirming a full cross section with a lumen in the middle of that vas deferens. Because when they don't do that, say they got a snip and they don't look at it, maybe they only snipped it partially and thought, or got like a sidewall or got a vein or something, or artery, you would think they would, or not artery, or a nerve, you would think that they would know what they're doing down there. But when that happens, the vas deferens can heal and pregnancy occurs. Happened to a few friends. So make sure you get that checked. Okay, so we're looking at here. So urethra, we talked a lot about it in urinary system last week. So it's 3 parts. It has the prostatic urethra, which is in the prostate. There's a membranous urethra, which is between the prostate and the penis. And then we have the spongy urethra, which runs through the penis and goes to the outside world. Okay. So here we have the male reproductive system a little bit more streamlined. Okay, so right here, we're looking at the posterior view. Here's the bladder. Here's our seminal vesicles. Okay. Here's our ductus deferens coming into here. Ductus deferens is going to meet the ejaculatory duct right here and join the prostatic urethra, membranous urethra, spongy urethra. So there are different types of bodies, or what's called corpus, or also known as bodies, that have different purposes. We have if we took a cross section right here, what I refer to as gizmo, don't ask me why. When I was in grad school many, many moons ago, we were doing our gross anatomy dissection, and I did not know what was cut in half in front of me. And I said, why is there a gizmo looking thing on the table? Didn't realize that we were in that section. Hopefully that made you laugh and not make you upset. Okay, so we have the corpus cavernosum, and those corpus cavernosum are surrounded by arteries, and that is the erectile body. There is an equivalent of it in the female clitoris as well. So what happens here is that the deep arteries, they relax, they fill with blood. Filling with blood causes engorgement of the penis and for it to become erect. We also have the corpus spongiosum, and its job is to anchor that urethra and give it some give, and also affects its ability to decide if it wants to urinate or ejaculate. And sometimes that does happen by accident the opposite way. Okay. So penis, there's a few parts here that I'll actually come back to this part right here. So biological men are born with a prepuce. A prepuce or a prepuce is a fancy word for a foreskin. Okay. In many cultures, in many societies, the foreskin is cut away, and it is believed that having foreskin can put you more at risk for HIV, but it is not super proven. As far as different parts, so this is a shaft right here. We have the glans, which is the head of the penis, right here. Okay, we already went over this part. And yes, you'll see a ton of times I was trying to make sure you're awake during this lecture and during last year's lecture when I gave it. So yes, I'm trying to see how many times I can write penis on a slide set to make sure you're awake. Okay, so penis, penis, penis. Okay, male perineum. So female and males have perineums. They just look different because there's different anatomy there. So male perineum starts at the area between the pubic symphysis right here and the ischial tube and ends at the ischial tuberosities, which is part of the hip bone, and consists of an area where the skin in embryology, when we're developing, is fused together and it meets up with the anus. Seminal vesicles, so they're the little bunny ears that hang off the prostate. Those bunny ears have a purpose. What they do is that when an ejaculation occurs, they have smooth muscle that can contract, and they add something to that seminal fluid. They make a very viscous, alkaline, so very thick, basic seminal fluid. It has high in fructose, citric acid, an enzyme that helps coagulate semen called vesiculase, and prostaglandins, which are inflammatories. Has a little bit of yellow pigment, so if you've ever seen those funny things about CSI or one of those room raiders from MTV 90s, they take a UV light. Yes, UV light does show semen because it has these yellow pigments in there. And then the seminal glands, sorry, make about 70% of the semen volume. Okay, so without these seminal glands, you're not having much of a semen production. Okay. Prostate, it looks about the size of a peach. It hangs just inferior to the bladder. It consists of smooth muscle that also contracts during ejaculation, and it has a job too. So its job is that it secretes a milky, slightly acidic fluid. And the reason for that, and this is also what gives the semen that little whitish egg white color, contains citrate enzymes and something called prostate-specific antigen. So when we're checking males for risks of prostate cancer, we'll check the prostate-specific antigen. If that has been raised or is too high for their age, it's indicative of a possible cancer. This prostatic fluid also plays a role in sperm activation, and it makes about 1/3 of the semen volume. And then we have the bulbourethral glands, which have a very similar similar purpose in the females as well. Pea-sized glands inferior to the prostate, 2 of them. They produce this thick, clear mucus during sexual arousal, and it's meant to lubricate the gland's penis. Also, we need that semen to be really basic for the sperm to stay alive, so neutralizes traces of the acidic urine that was in the urethra beforehand. Okay. Two types of diseases you might hear about are benign prostatic hyperplasia, known as BPH. Typically affects men about 50% above. This can lead to enlargement of the prostate. Basically, it's enlargement of the prostate, and what it does is that a large enough prostate can squeeze on that prostatic urethra, causing urinary tract infections and other conditions. Normally, there are drugs that are either used to relax a smooth wall, as tamsulosin. There's also drugs that help inhibit some of the testosterone made into a more potent form of testosterone in the body that causes this BPH. We try to inhibit that. And sometimes we just go through the urethra and take out the extra pieces of prostate around the urethra so we can widen the prostatic urethra to allow for peeing. And we also have prostatitis. So itis means inflammation of the prostate. 2 common reasons for this to occur. Acute prostatitis is normally because of sexually transmitted infection. Chronic prostatitis is normally due to BPH or some other. And then prostate cancer, we already spoke about that. So semen, we already talked about what's in there. So fun facts about semen, there's each ejaculation is about 2 to 5 milliliters, so about half a teaspoon. And about 20 to 150 million sperm are being produced in that aspect. And the fructose is in there for a reason, because it helps with ATP production and protects and activates the sperm and helps the sperm move. And we'll learn in the female genital tract that the vaginal canal is very acidic, as it should be. It helps inhibit overgrowth of bad for us bacteria or yeast. And then the alkaline fluid that comes into the out of the male urethra, alkaline fluid that is ejaculated is neutralizing the acidity of the male urethra, but also the female urethra, and this causes the sperm to be much better swimmers. Okay. And other fun fact is that sperm are technically, when it comes to the terms of reproduction, are foreign invaders to the body that it's going to be in. So in the biological females, it helps, what it does, it helps suppress the immune response in a female to recognize as foreign invaders, so we can actually have a baby out of it if that's what you should so choose. Okay, so male sexual response, is important to know about this because there are certain drugs that you will be using and certain conditions that you should know about. So we have a way to remember this, and it's kind of vulgar, but it's the best way to remember it. It's called point and shoot. And why do I say that? So erection is enlargement and stiffening of the penis. We need something called nitric oxide that is released after having some parasympathetic nervation. So that P is parasympathetic, P for point meaning erection, okay? And then what happens is that the smooth muscles in the vessels relax, causing arterioles to dilate, blood engorges the penis. Corpus spongiosum is able to keep the urethra open. And how does this happen? It's by sexual stimulation, but sometimes just the smells, sounds, and sights. And a big thing that we look at as far as in medicine is that emotions or higher mental activity can definitely inhibit erection ability. Fun fact is that I always screen males from 25 and older for erectile dysfunction. Why? It's not to embarrass them, and it's actually not to do with mood. It's a really good indicator of cardiovascular health. So those who are more prone to cardiovascular disease or been shown to more likely show erectile dysfunctions earlier on. That's our first warning sign. So when I start hearing that, I start looking for cardiovascular issues. So the ejaculation part is the shoot. So we have the point, parasympathetic, the erection, and then ejaculation is shoot. And shoot means sympathetic, because ejaculation is a spinal reflex that occurs when enough stimulation is achieved to produce an orgasm. This causes increased heart rate, increased blood pressure, and is meant to cause intense pleasure. And that causes the reflex to occur, and the semen is ejaculated out, and that is sympathetic, okay? And then in men, ejaculation is followed by resolution, where the muscles and the psychological aspect of it needs to relax. So there is a time period where a biological man, may not be able to achieve another orgasm for minutes to hours. And depending on how old that person is, sometimes the younger male, they have a shorter period, and older male has a longer period of this. Already talked about erectile dysfunction and the spermatogenesis. So how are sperm formed? Let's chat about that. We're going to chat about that more in meiosis, and it's going to be a big review for you in the next coming weeks. So I'm really happy we're going over this now. Spermatogenesis, genus means to make. So we are making more male gametes. So remember, it occurs in the seminiferous tubules. It begins at puberty. It says here around age 14. That is when sperm formation starts, not puberty. And adult males can make about 90 million sperm per day. So fun fact about females is that females are born with, or biological females are born with all the eggs they will ever have in their lifetime. Biological men make them on a daily basis. We have different types of cells that are present in the seminiferous tubules that help us with, help with the formation of new gametes. We have Sertoli cells, and these help us with sperm formation. We have spermatogenic cells, and these are kind of stem cells that give rise to sperm. We have myoid cells that are muscle cells that help the tubule squeeze out the sperm. And then we have Leydig cells. I will never refer to them as the other name, Leydig cells, and they produce androgens and some estrogen. So this is what they look like under the microscope, under an immunofluorescence tagging. Well, let's talk about how do we get sperm to divide and be able to reproduce. So remember, spermatic cells are the precursor. So first we have mitosis, and mitosis is cellular division, not reproductive division, but cellular division. So cellular division of the stem cell occurs, and you get 2 spermatocytes. From these 2 spermatocytes, then we have meiosis, and meiosis forms in 2 steps. Meiosis 1, meiosis 2. Then we have something called spermiogenesis, which is the formation of sperm, where the meiosis 2 leaves us with spermatotids, and those spermatotids then become sperm. And it's important to know that spermatogonia, the precursor cells, the stem cells of gametes in males. So I'm going to try to attempt to do this water again and not spill it on myself. Goal accomplished. Boom. Okay. Type A daughter cells, they're always hang out in the basal lamina of the seminiferous tubules, and they're kind of the blueprints. They're always going to be there to be a blueprint. And then we have type B daughter cells, which their job is to go towards lumen and become into primary spermatocytes. So we're taking a look here at a bigger view. I'm actually going to, not too much. Can we get to a happy medium here? No. Okay. So spermatogonium, these are diploid. Diploid means it has 2 pairs of chromosomes. So if you remember a little bit from the beginning of week 1, we talked a little bit about chromosomes. So spermatogonium, 2 pairs of chromosomes is called 2N. They go through mitosis to make a type B daughter cell. Goes through them growth, goes through growth here, and then it goes from meiosis 1. And meiosis 1, we have a primary spermatocyte, which is still 2N, still diploid. Then once this is completed, we start meiosis 2. So meiosis 1 is completed when we're left with just about at the secondary spermatocytes. Secondary spermatocytes here. So when meiosis 1 is completed, we are now, sorry, let me back up. So primary spermatocyte in meiosis 1 is going to split into 2 different cells, but it's going to split its genetic components. So it's going from diploid to haploid, so 2N to 1N. So then we have secondary spermatocytes, and those spermatocytes go through meiosis 2, and those spermatocytes now form 4 spermatotids. And these 4 spermatotids end up, so sperm are actually not born with tails. As they mature, they grow their tails. Okay, let's bring this back to normal view. Okay, so exactly what I said on that slide is on these in words, okay? So a little bit of the progression here. So I just pointed, like you can see me point into the ether here. You're just seeing here the progression of a no tail to tail, and this is a flagella. It whips back and forth to help swim. And in lab, you'll see a video of it actually, of this sperm swimming. And then spermatogenesis takes about 64, 72 days if conditions are hospital. So good health, good sleep, good temperature, good hygiene. And then sperm, remember, when they're first made, are unable to swim from the testes, but the pressure of the testicular fluid pushes the motile sperm into the epididymis. And what happens to the epididymis? They mature, they grow up until they're ready to go out to see the world, blah, blah, find their eggs, or not. And then we have the Sertoli cells. So Sertoli cells are supporting cells inside the seminiferous tubules. And they literally do what they do. They help support the other cells. And then we have the blood testes barrier, and these are tight junctions, and they prevent antigens from escaping the blood and causing activation of the immune system. Because sperm is not formed until puberty, if we don't have this blood testes barrier, the body will recognize sperm as not self and try to attack it. And then Sertoli cells, they do 2 things. They secrete testicular fluid, and they also secrete something called androgen binding protein, and this helps keep testosterone levels high to stimulate spermatogenesis. And then when inhibin is secreted, it inhibits spermatogenesis by inhibiting FSH. So FSH is going to trigger androgens, okay? And this is just a funner look at it. Infertility is a huge issue in this country. Over the past 50 years, male fertility has been on the rise. I don't know if it's because of Mountain Dew. I don't know what. Well, I do know, but I think it has something to do with what we're eating, pesticides, herbicides, phthalates. This was not in your book. This is something I added. That's just my clinical opinion. Okay, another possibilities is that there's sometimes compounds that look like estrogen that actually block testosterone. certain antibiotics can do things. And I hate to say for anyone who loves to smoke their weed and drink their gin, it is not good for sperm production if you're trying to conceive. And then, of course, we talked about how everything's regulated. The big key here is that HPG axis. It's involved the GnRH, FSH, LH, testosterone, inhibin. Testosterone is an androgen, okay? So how do we the regulatory events that you need to know about? So GnRH gets stimulated. GnRH goes to the anterior pituitary. FSH gets secreted. FSH is going to stimulate the Sertoli cells to release androgen binding protein, which is going to increase the local testosterone production. And then we have luteinizing hormone, which comes out that also helps the Leydig cells make testosterone. Okay. And before birth, male infant has about testosterone levels about 2/3 of the adult. Okay. Some male babies and even female babies are either born, biological male babies can sometimes be born with a swollen scrotum or swollen breast buds, and that has to do with the estrogen that the mom was producing. Okay, so we don't really need to go into that much here. So there are some things about testosterone that you need to know about. So testosterone is converted in the prostate to DHT, which is dihydrotestosterone. And this is the more potent form of testosterone. This is what testosterone has an anabolic effect throughout the body, which means it helps it build, which is why we hear about steroids being injected, because it does help build muscle replacement. But here's what the bad part about it is that when we don't have enough testosterone, then, or DHT in general, then we have atrophies of those accessory organs. You don't have enough semen production. Erections are horrible, and then we have to do testosterone replacement, which is becoming more common these days. The other issue is with steroid injection. Think about it. We're giving the body testosterone, and it works on a negative feedback loop. We're giving it artificially when there was no deficiency. So we're telling the FSH that, hey, we got enough testosterone, stop making it. So it ends up happening is you get all these effects of testosterone, which is anger, fits, acne, muscle mass, but you also get atrophy of the testicles and inability to make testosterone on their own. As far as male secondary characteristics, these are either biological male or people who are transitioning from female to male. The idea here is that the secondary male characteristics are pubic, axillary, and facial hair, chest hair, larynx becomes enlarged at Adam's apple and causes deepening of the voice. Skin can become thick and oily, bones grow and increase in density, skeletal muscle mass rises, which you can imagine what we just talked about. Testosterone is really important for boosting metabolic rate, the resting metabolic rate, and the sex drive or libido in males. And I'll say that it also has an influence on females. Okay, take home message about what I was trying to say in the most awkward way possible is that gender is different from sex. Sex is something, and at least from scientific standpoint, I'm not going by religious or viewpoint standpoints. I'm going from a scientific standpoint that gender and sex are different. Sex, biological sex, is something that your chromosomes have inherently born with, as far as that. It doesn't have anything to do with how you think, which is your identity. Gender identity, some people identify as woman, some identify as man, some go in between, and that's totally okay. Orientation is who you love, and you can love whoever you want. And then gender expression is regardless of how you identify as, how you like to express your gender. There are many men who love to wear dresses, and that's cool. There's many females who associate themselves as feminine or female, but they have a more masculine expression. There's people who also just want to look plain down the middle, androgynous. Think of David Bowie. So I hope that was helpful. Look forward to seeing you guys for reproductive. I did not mean to offend anyone or make anyone giggle or make anyone feel uncomfortable. And I always add the genderbread person because I don't feel like it's taught enough in schools. So if this is troublesome to you, I apologize, but this is just what I feel is important for you guys to know. All right, have a great day.